today is how often do I need CLL tests? Here is the agenda for today. I'll introduce our speaker, Dr. Nitin Jain. Dr. Jain will then give us his presentation. After the presentation, we will open it up for your questions and comments. So let me take a moment to introduce our speaker. Dr. Jain is a professor of medicine in the Department of Leukemia at the University of Texas MD Anderson Cancer Center in Houston, Texas. He earned his medical degree from the All India Institute of Medical Sciences in New Delhi, India in 2002. He completed internal medicine residency at the Medical College of Wisconsin, Milwaukee. He then completed clinical fellowship in leukemia at MD Anderson, followed by a leukemia research fellowship at Memorial Sloan Kettering Cancer Center. He then pursued fellowship in hematology oncology at the University of Chicago. He joined as a faculty in the Department of Leukemia at MD Anderson in July of 2012. Dr. Jain treats patients with acute and chronic leukemias, with focus of patients with chronic lymphocytic leukemia and acute lymphoblastic leukemia. Dr. Jain's research interests focus on new drug developments for patients with leukemia, especially CLL and ALL. Since 2021, he has also served as director, Leukemia CAR-T program within the Department of Leukemia, MD Anderson. Dr. Jain is a principal investigator of several investigator-initiated phase 1 through 2 clinical trials. He has published papers in prominent journals and won many awards during his career. So with that, I'm going to turn it over to Dr. Jain.
Hello. Good evening, everyone, or good afternoon. Let me share my screen here. So first of all, thank you all for joining today for this wonderful patient-focused webinar. And so my intent here is to talk to you today about CLL. I think the topic, it says, how often do I do tests for CLL or clinical tests, and we can certainly talk about it. The presentation I have for you here, maybe in the next, for the next maybe 20 minutes or so, it's just going over some brief overview of CLL, and we'll certainly talk about tests in CLL, what we do, the genetic tests and things like that. And then, importantly, once I finish, we will have ample time for Q&A. If you want to, have any questions about the topic, which I'm sure you guys will have. So with that note, I'm going to get started. So as was mentioned, I'm in the Department of Leukemia at MD Anderson in Houston, and primarily focusing, seeing patients in the clinic with CLL and SLL. That's constitute a large part of my clinical practice. I also treat patients with acute leukemia and other leukemias, and also kind of lead our CAR-T effort within our Department of Leukemia for CLL as well. So some of these, again, depending on who all has joined, people may have different level of understanding of the disease. So it's what I'm going to talk to you about is a very big picture overview of things, at least in the slide part, but we can go into more specifics in the Q&A. I think some of the questions people have when they come to see me, and in general, will be, okay, what is CLL? Why do I get CLL? I think very common scenario I see in my practice here, and I get almost 2 or 3 patients each week I see here who are referred, are largely because of the fact that they have diagnosed with CLL and their local oncologist has told them that they don't need any treatment. And that creates an anxiety about the disease, that why the CLL is not being treated, what is my prognosis? And that's one of the most common scenario really I see patients here. And then there are patients who certainly would need treatment. Why do we need to treat someone with CLL? What are the reasons to treat someone with CLL? What therapies are available? And I'm just going to talk about a very big picture view here. And then there are treatments for relapsed patients who have relapsed means patients who have had some treatment, their leukemia has come back. And we're not, I don't have, I'm not included slides here, but certainly happy to chat in the Q&A about if you have questions about relapsed CLL treatment. So what is CLL? So this is in big picture view, CLL is a cancer of the lymphocytes, and lymphocytes is a type of our WBC, white blood cells. And, an important point, I think, is that it's a chronic leukemia. So CLL stands for chronic lymphocytic leukemia. So it's a chronic leukemia which is different from maybe the connotation people hear when they hear the word leukemia. People think of acute leukemia, that is kind of bad and it needs treatment right away. And that's only true for many different kinds of leukemias. But this is a leukemia, which is a chronic leukemia, which goes on for months and years. And actually, the most common scenario patients are diagnosed with is that they have no symptoms. They just go into their doctor for a routine CBC, primary care doctor, or maybe someone is getting a mammogram, they see a lymph node in the axillary area. They got a CT scan for a totally unrelated reason, and oh, there's some lymph node present. So really have no symptoms, and then they are diagnosed with further testing leads to the diagnosis of CLL. So really, they will have no symptoms, and it's like a really shock that, oh, you have a leukemia, because they have no symptoms. But this is exactly the most common presentation. And the average age of diagnosis in the United States is about 70 years. So 70 to 72 is considered the median age of diagnosis, which also means that median means, half. So there are patients who are 75, 80, 85 at the time they're diagnosed. And there are patients who are in their 50s. Certainly CLL is rare, less than 40, but I have several patients in my practice who are less than 40 years of age, including a patient, she was only 18 years of age, which is probably one of the youngest CLL you will ever maybe hear about. So, it's a disease overall of patients in their 70s. So how we suspect CLL? So most of the time, as I said, it's basically a blood test. That's the most common scenario. And someone put in the chat box, I guess their dermatologist diagnosed as well. So that will be a less common scenario, but rarely you can have some skin issues and kind of skin lesions as well. Most common will be the blood test, or patients can have swelling of the lymph nodes. Now, once that we look at the blood count and it's showing what is called a lymphocyte count is high, it's very suspicious for CLL, though I would say that there are other disease, it could be just be elevated from a viral infection or something like that. So common things being common, more people in the world will have viral infection than CLL. So if it's elevated one time, it's certainly a good idea to recheck it maybe, a couple of weeks later. And that's what happens most of the time. That is still high, then patients are generally sent to a hematologist or oncologist to further workup, where the test, which is listed here called flow cytometry, is done. And flow cytometry is a test. Basically, what it looks for a certain number of proteins or a certain type of proteins on the surface of these cells. And there is a specific configuration, I should say, which marks a CLL cells. So it's actually a very relatively easy diagnosis. It's just you can do it on a simple blood test. You don't need a bone marrow biopsy. You don't need a lymph node biopsy. For most patients, just the blood would suffice. There are patients who will need bone marrow and bone marrow lymph nodes, but I would say 90% of the patients, you can just do a blood test and that's it. And that would confirm the diagnosis of CLL. But in specific scenarios, we have to differentiate it from other conditions, because there are other lymphomas which are CLL-like, but they can mimic. And sometimes those things become difficult to sometimes distinguish and may require a bone marrow biopsy or a lymph node biopsy. But again, majority should be able to be diagnosed just on the basis of blood test without the need for any other biopsies to say. And as I said in the last sentence, sometimes we do need to do additional tests. The picture I'm showing here, and this is more, I guess, so you may have heard sometimes people say smudge cells, or you may see smudge cells being listed in your report of your blood test. And what a smudge cell is, and what is highlighted in this black arrows, is really these smudge cells, which is basically the CLL cells. So these are all CLL cells, which I'm kind of pointing out arrows. But when they make the slide, they kind of they put one glass slide and this move another glass slide over it to make kind of a smear. And during this smearing phase, these cells burst open and they become like smudge. They smudge the smear. So this is not how they're in the bloodstream. This is just an artifact of making the slide, basically, because these cells are fragile and they just burst open. So this is in the medical terminology, we call it smudge cells, which is not that it's 100% indicative of CLL, but it's just one of those things which is very common in CLL. And it's kind of for people when I give this talk to maybe medical students and things like that, is one of those questions they have to remember because smudge cells is indicative of CLL. But that's what the smudge cells are, which you sometimes may see. Now, how common is CLL? So each year about 20 to 21,000 patients are diagnosed with CLL in the United States. So this is just the US number I'm telling about. And again, as I said before, it's about 70. Most of the patients are in their 70s. The specific cause is still unknown. I mean, I guess we don't know. There have been studies looking at different exposures and things like that, but I would say for vast majority of the patients, we cannot pinpoint a specific cause or something which may have led to CLL. Another common question comes up is that, are my children at risk for patients who are diagnosed with CLL? And I would say, the risk, there are patients in which there will be another family member with CLL, like a brother with CLL, or their dad had CLL, or mom, or, so there will be one or two family members with CLL. But again, that's a relatively uncommon scenario. Most patients will not have another family member with CLL. They're just the first one and they're diagnosed with it. Now, people have studied and trying to see, if there is some kind of a gene which goes from one person to another, and they can track it and see if you have CLL, maybe there's a abnormal gene you have, which then we can check in your kids if you have it. But unfortunately, that kind of a thing has not been established in the context of CLL. So there is no one gene which you can track or do that. So in general, there is no specific recommendation of any testing or anything needs to be done for children or basically for family members at this time. As I said, some patients will have multiple family members, but that's somewhat of it's not a common kind of a scenario. So when you are diagnosed with CLL, as I said, the testing is the flow cytometry and easy. It's easily done, and you can, get the diagnosis. Now, there are additional tests which we tend to do to further characterize the CLL, which will help assess the clinical behavior, because not all CLL cells are created equal. Their genetics are different. Within the context of CLL, they have different genetics and genomics, and if we assess them properly, we can help predict, or it's just a guesstimate to say of when a person may need treatment or what treatment we may consider, how well they respond to treatment. So these tests can help in all those things. As is stated here, there are some patients who will live decades without needing treatment. In fact, they may live the rest of their natural life without needing CLL treatment. But obviously, there are others who will require treatment, sometimes 5 years, 7 years, 10 years. And there are some patients who may require treatment practically on day one, and that's a less common scenario, but there are patients who come with very, very high white count. I had a patient recently, she came with a white count of 900,000, that's probably one of the highest white count. And that was just her day one. That's what she came, and, she came with very sick, and she's doing fine now. But those are rare scenarios. But yes, patients can present with very bad disease, bad aggressive disease. But most patients it will take years before they need treatment. So let me see if I miss it. Oh yeah, so this is an important slide. So what test we do, and at least this is a testing which we do at MD Anderson, but many other major CLL centers have similar testing algorithms to say, or testing panel they use. So one of the most important tests you could do in a patient with CLL is a CLL FISH panel, which categorizes patients into different so-called FISH. FISH panel here stands for fluorescence in situ hybridization. It's just a medical term where we're looking at specific genetic abnormality inside the CLL cells. And it can be easily done in the blood as well. All the tests listed here can be done in the blood. So you really don't need a bone marrow or a lymph node to get these results. You can just get it on the blood. And that characterizes patients into what is called deletion 17p, 11q, 13q, and patients who have, patients who are online, and they may know this about their disease, from their oncologist. The other test is called IGHV status, which is really categorized into two, mutated and unmutated. Here, having a mutation is actually a good thing. So mutated IGHV behave, those patients, their disease tends to behave at a slower pace. Unmutated IGHV tends to be a bit more aggressive in terms of how the disease multiplies. And then the last one, which is also a very important test, which I would say many times gets missed being done, is the TP53 mutation status. Most of the time when I see patients, they will have the CLL FISH panel and the IGHV testing done, but they generally don't have TP53 mutation status done, which I think is a very important test as well, because it has important connotation in terms of treatment and whatnot. And that's another test which could be done again on the blood, which you do not need any bone marrow or lymph node biopsy. Now, so once we see a patient, we discuss that the patient does not need treatment. I guess one thing maybe I should mention here is that there are specific guidelines, specific reasons which have been established for patients with CLL when they need treatment. And there is some what you call and some of these guidelines or the recommendations are based on the blood counts, lymph node, if they're becoming big, they're having symptoms, spleen becoming bigger symptoms, or if you are having too much symptoms from the disease that is significantly affecting your quality of life. So every time you go to the oncology doctor, they should be asking you about your symptoms, checking your blood test, as well as obviously examining you and trying to assess if you are approaching a time when you need treatment. And these are some general guidelines, which again, but there's nothing I would say hard and fast here, but generally for the first year, I generally say 3 to 4 months, you can get your blood counts checked and see the doctor for the first year. And then after year 2 and beyond, it can be slightly less frequently as well. I would say there are patients who are 10 plus years and I see them once a year. So it generally 3 to 4 months early on, and then depending on how stable the disease is, you can lengthen the interval between the visits. And again, there are other things which may be required over time. One thing I would say is that the CT scans are generally not recommended to be done routinely. You can do CT scans if you're having symptoms and you're having worsening disease, you're having lymph nodes, you say, I'm having back pain, I don't feel right, I think what symptoms are worsening, then yes, doing a CT scan makes sense because you want to see if the lymph nodes are worsening. But let's suppose you have no symptom, you feel fine. There's no reason to keep doing. Sometimes I see every year CT scans being done and things like that, which is really not required, and it's unnecessary, I think, exposure to radiation and whatnot. Now, the last point here is actually an important one. Patients with CLL can have increased infections, especially sinus infections, upper respiratory tract infections, things like that. And in these scenarios, we do recommend that you should check what is called IgG levels, which is serum immunoglobulin levels. And the standard recommendation is that if your immunoglobulin level is low, typically less than 500, and you're having recurrent infections, which is affecting quality of life, or at least one hospitalization each year, then you should, your doctor should or recommend supplementation. It can be given once a month infusions of IgG. So just having a low IgG is not a reason to treat. It has to be accompanied by infection. So that's very important, that it has to be accompanied by infections. But that's something which, sometimes can dramatically improve a patient's quality of life if they are suffering from all these recurrent infections, sinus infections, whatnot. And sometimes you start IVIG, and after that, absolutely no infections. So it can work really well for some patients. There are other standard recommendations. So I think one important aspect is that cancer screening is very important. So what I'm talking about here is cancer screening like prostate cancer, colon cancer, mammogram for breast cancer, skin cancer. Patients with CLL are at a slightly higher risk of these cancers. So we recommend that you should get age-appropriate screening. There's no recommendation to do excess screening, but whatever is recommended by your primary care doctor for your age group, colonoscopy, PSA for men, mammogram for women, skin examination. So those should be done, as per the recommendation. The other recommendations here are pretty standard, weight management and nutrition and regular exercise. I do emphasize patients to continue to follow up with their primary care physician, and especially if they have a cardiologist and a nephrologist and other disease specialists, they really need to continue to follow up with them closely, because their CLL may stay in the back burner and may not give any issues for who knows years to come. But if you don't follow with a cardiologist, that could be a big trouble and not managing your blood pressure or your heart issues. And because of the skin cancer risk, we do recommend a dermatology visit yearly so that they can look for skin lesions and remove them and kind of follow along. And the last maybe 3 or 4 slides, I'm going to talk about some big picture overview of CLL, and then I will stop and then we'll kind of open up for Q&A. I see something popping up on Zoom, so I think maybe there are some questions in the chat box, but we'll address in a few minutes. So in terms of the treatment of CLL, I think I just going to give you a big picture overview. But one thing I think patients who are on the call or who may listen later, many people may be on a drug called ibrutinib or may have heard of a drug called ibrutinib or ibrutinib-like drugs. But I think it's important to emphasize that the ibrutinib was approved for CLL in February of 2014, so just about 10 years ago. So we are now into 1 decade of these new therapies, which have really changed how we manage patients with CLL. 5 years ago, 10 years ago, we were using chemotherapy and these new drugs were coming along, but still the standard was chemotherapy. And now we're absolutely not using chemotherapy at all. So you should not get chemotherapy at any case for your CLL. I think that practice is going away in the United States. But sometimes, but really no patient with CLL should be getting chemotherapy in today's era, at least in the United States, where we have availability of all these new drugs. This slide is meant to kind of maybe show you how over the last, this slide goes in the last 50 years to say, but up until 2014, kind of the slide I showed before 2014, we only had chemotherapy. And some of you may have received drugs such as FCR or BR. These were chemotherapy which were developed in year 2000s and really were the standard. But now since 2014, 2023, and now 2024 and kind of moving beyond, everything which is listed here is all targeted therapies. Many of them are pills and they work fantastic and they work better than chemotherapy. So it's kind of, so we have multiple therapies and agents available for patients with CLL, at this time. And my basically last slide, again, I want to just give you a big picture overview. Rather than showing you multiple slides with data, which again may not be very helpful for many people here, is that at least for newly diagnosed patients with CLL, at least in the United States, we have 3 drugs approved: ibrutinib, acalabrutinib, which can be given with a drug called obinutuzumab, which is an IV drug, or zanubrutinib. Ibrutinib, acalabrutinib, and zanubrutinib are pills, and they're supposed to be recommended to be taken indefinitely. So you basically keep taking it every day. And I have some patients who have been taking ibrutinib for like 11 or 12 years, and some patients who are taking acalabrutinib for like 10 years. So these drugs can be given for a long time, or patients can respond for a long, long time. Or you can have a time-limited approach, which is typically about for a 1 year, where you combine a pill called venetoclax with a drug called obinutuzumab, which is IV. And there are some strategies where you can combine two pills together. The approved strategy is venetoclax plus ibrutinib, but is approved not in the United States, but outside of US and like Europe and Canada and other countries. So it's really not really an option in the United States. So at least at this time, the current discussion really resides whether a patient wants to take or go on this pill a day, basically, or one pill twice a day, indefinitely long term, versus they want to take a 1 year approach, which has an infusion involved and can be a bit more logistically involved early on. I should also mention that over the years, there have been studies done which have shown that though ibrutinib was the first kind of poster child and really the first one in the market, really changed how we manage patients with CLL, but now there are safer versions of ibrutinib which have become available, namely acalabrutinib and zanubrutinib. So in our practice, we are really not using ibrutinib anymore. Our practice is to either use acalabrutinib or zanubrutinib, one of these agents, or use this 1 year approach of venetoclax plus obinutuzumab. And again, this is only talking about patients who need their first line therapy, like this is their first therapy. When we go in the relapse refractory patients, it's a much different ballgame. The agents are similar, but how we use them basically depends on what they have received before, what was their response, and side effects. So many factors kind of come into play when we decide therapies for patients who have relapsed disease. All right, so I think this was hopefully a very big picture overview for you guys. If this is just my email address, if you have specific questions, you certainly are more than welcome to email me, and I'm happy to take any questions. So I will stop sharing now, and maybe we'll see if there are questions here.
Thank you so much for your informative presentation, Dr. Jain. We do have some questions in the chat, and let's go ahead and get those answered. As well, a reminder, if you would like to make a question verbally, feel free to raise your hand, and then we'll call on you. Okay, so the first question in the chat, Carson, I believe he answered that a little bit earlier. Your CLL was diagnosed during the dermatologist appointment. If you have any follow-up or further concerns, we can chat about that. You're okay? All right. Okay, so Seymour, Dr. Jain, Seymour has a question. If the FISH panel shows deletion 17p/TP53 mutation, oh, I apologize, /TP53, is that the same as TP53 mutation status?
No, so that's not. So the FISH test, so very good, important question actually raised. So deletion 17p is assessed by a FISH panel. TP53 mutation is assessed by a mutation sequencing panel. They're both looking at slightly similar thing, but they are different things. You know, they're the same. So deletion 17p means deletion of a part of the chromosome 17. TP53 mutation means that the chromosome 17 is present, but a gene called p53 or TP53 has a mutation. So these are two different kind of connotations, meaning. So a FISH panel can only show you deletion 17p. For TP53 mutation, you will have to assess, you have to get a gene sequencing panel done. Now, there are patients, so about half of the patients, or 50 to 60% of the patients will have the two together. So they will have deletion 17p and p53 mutation both. But the rest of the patients can have one or the other. So you could have deletion 17p, but not have TP53 mutation, or you can have 13q or 11q, like something else. No 17p deletion, but your gene panel will show a TP53 mutation. So if you don't test for TP53 mutation specifically, you may miss that. You may miss that because if you're just relying on FISH. So yes, there is a big overlap, but then there are patients who do not have 17p deletion by FISH, but they will have a TP53 mutation. So it's important to assess for those because they are assessed by two different testing platforms. I think you also asked about insurance-acquired IgG. I think we sometimes run into issues. I would say, I mean, I generally say that less than 500 is reasonable. Now, I think if you're 500 to 600 and you want to get it because you're having frequent infections, I mean, certainly, I don't think insurance has at least given us trouble in that. Sometimes what we encounter is patients who are on IVIG and then their IgG levels are good, like 800, 900, like they're in the normal range now, and the insurance will say, why do we still need to give it? And that sometimes becomes a bit of a challenge to kind of convince them, because it's an ongoing therapy is important to maintain the level of IgG above 600 range.
Thank you for answering those questions. Seymour, I hope that answered them. If you have any additional insight on that, feel free to let us know. Okay, the next question from Holly. She's asking, my IgH somatic mutation status is inconclusive. What does this mean?
Right. So about 10% of the patients with the CLL, the testing platform which has been done will show inconclusive result. Now, it could be just a matter of the testing platform. We used to have an older testing method at MD Anderson, where I would say maybe 10 to 15% of the patients, the result will come back inconclusive, where basically it means that they're not able to do it. And then about maybe 4 or 5 years ago, we got a new testing platform where now I hardly see inconclusive. Always there is a result, So I think it may be issue with the lab, or not lab per se, but just the technique. So if you were to have maybe another, so there are two ways you can do it. There's an RNA method and a DNA method. My understanding is that the DNA method is more conclusive, or it's less likely to be inconclusive. And that's what we use at MD Anderson. As I said, up until recently, we were doing the RNA method, which was you get that. So it's a bit of a challenge sometimes. There are some patients, but I suspect if and I see you have a follow-up. You said that it was Duke, but again, it will be helpful to ask them if it was an RNA or a DNA sequencing method, and if it was an RNA sequencing method, maybe see if they can send it out, or there's a third party you can use to assess by another methodology for the IGHV.
Thank you for answering that, Dr. Jain. And Holly, I hope that answered your question okay. Okay, the next question that we have from Cindy is, I have atypical CLL with deletion 17. How often should I have appointments?
So it's there is no, I mean, as I said in my presentation, I mean, generally for 17p deletion, I would say in the first year, every 3 to 4 months. Now, again, it really depends on how the patient is doing. If you have really first few years, 1 or 2 years have gone by and your disease is absolutely stable or relatively stable, I would just keep maybe every 4 months then. But on the flip side, if you're starting to see these signs of disease progression, I think slightly more frequent follow-up is appropriate. So I don't think there's a kind of, it's just how a patient kind of behaves with time. But early on in the first year, I may say every 3 months, 3 to 4 months would be an appropriate thing to do.
That's good to know. Well, thank you for your response there. The next question we have from Janet. She's asking, how can obinutuzumab infusion reactions be avoided?
Right. So infusion reactions to obinutuzumab are actually quite common. And it really depends on how much disease you have, meaning if you have a lot of disease, white blood cell count is high, lymph nodes are high, are big, you will have more infusion reaction. Certainly, you should get pre-medications with like steroids and Benadryl and all the, so there's a cocktail of pre-medications you get with these infusion reactions to prevent them. So certainly that would be important to do. Other than that, now patients who are, for example, using acalabrutinib or zonibrutinib or some kind of what is called a BTK inhibitor, there have been some studies which say, and if they're using it in combination with obinutuzumab, there have been some studies which say that if you start the BTK inhibitor before obinutuzumab, maybe let's suppose the day before or something like that, that could help curtail some of the infusion reaction. But in general, it's just the pre-medications, which you should be getting as part of the reaction to prevent it. But again, even with that, about 15 to 20% of the patients will have somewhat of a serious reaction with the obinutuzumab. And it also important to remember, it's really with the first 1 or 2 doses. It really never happens on the day 8 infusion and beyond. It's really the first initial couple of doses.
Janet, I hope that answered your question okay. Want to make sure I get to everybody. So if we go a little quick here, not trying to rush, just trying to make sure that we have everyone taken care of. Okay, so Gary here is stating he's a 76-year-old male, has been in watch and wait for 10 years now. We'll start zanubrutinib in January 2025. White blood count is 1, so 112,000. HBG is 11.5, platelets 58, as he's had all 3 skin cancers, has had 3 IgG infusions. The last one caused a severe rash that lasted for about 5 months. As he has 1 kidney, can he still take zanubrutinib dosage without kidney impairment?
Well, as long as your kidney function is fine, your creatinine is fine, that should not be really an issue. These drugs are not per se BTK inhibitors like zanubrutinib are not does not call what is called tumor lysis syndrome. So so if you have 1 kidney, that should be okay to take zanubrutinib as long as your creatinine is okay. Just when you started, obviously keep yourself well hydrated. Drink maybe 1.5 to 2 liters of water every day, at least for the first maybe 1 or 2 weeks when you're starting it. But that's pretty much it. Yeah.
Thank you for your response. Oh, I do see, Gary, you had a slight more to your message. So he's also had shingles for 6 weeks. He now has PHN, which is very painful, and his doctor wants to wait a bit for his immune system to get better prior to treatment. Okay.
Yeah. Okay, yeah, so that's kind of a tough. So you should be taking, you may be on Valtrex already or Valacyclovir, but that's something now you should take it for the rest of your life, even after you finish your CLL therapy.
Thank you for your response, Dr. Jain. Okay, Seymour had a follow-up question. Can FISH type or IGHV mutation status change on a later test?
Yeah, it's a fantastic question. So FISH can change. And we do recommend, or at least in our center, whenever a patient progresses and they need some other new therapy, we recommend checking a FISH test again. However, IGHV mutation for individual patient practically never changes for their lifespan, so it stays the same. So you just need IGHV mutation testing to be done one in your lifetime to say. In fact, our lab, if you were to send a sample again, they will say, oh, patient had it 5 years ago, we'll cancel the test. They won't run it. But FISH can change. TP3 mutation can change. So those needs to be repeated, but IGHV is a one-time test only, really, and you don't need to repeat it.
That's good insight. That's interesting that one of them will never change, but the deletions can change.
Right.
Awesome. Thank you for your answer there. Holly had a follow-up that the test from Duke stated it was extracted DNA.
Yeah, so the DNA is actually more sensitive. We also use DNA. So, I don't know, maybe they can run it again. Otherwise, maybe you can come to Anderson. We can try to do it here. But that's the test, or we also use the DNA test these days. So, but I mean, again, even with that, I mean, as I said, maybe there'll be 1 or 2% of patients we see where the test fails, but generally it's so again they could run it again and see if they pick it up.
And then just to confirm, she is asking, you had stated that RNA or DNA was more likely to be inconclusive?
RNA more likely to be inconclusive, so better is to do a DNA test.
Okay. Thank you for that. Okay, Tom has a question stating, my CLO transformed to DLBCL, germinal cancer subtype. After 6 cycles of R-CHOP, I had CR which continues today for 21 months. I also had 18 radiation treatments for my right groin. 21 months later, I feel good. My blood work is normal except for lymphocytes, which are 800 on a scale of 1400 to 4800. Is this unusual for RS? What should I watch out for? I am 76-year-old.
So I won't really be concerned about, it looks like, first of all, this is really great that you had such a nice response to R-CHOP therapy, which is fantastic. Having a slightly low lymphocytes, it looks like your lymphocytes are slightly running on the low side, which is fine. Sometimes that can happen. I would be more concerned on the flip side, obviously, that if your lymphocytes are rising and rising, then that would sometimes indicate that, the CLL part of the Richters is kind of coming back. But at this time, really nothing special. I mean, watch for in the sense, obviously blood counts and symptoms. Uh, you may be getting, sometimes we do PET scans. I'm sure you had PET scans in the last couple of years of your treatment. But those will be sometimes help to see if some kind of a lymph node is coming back or things like that. But the longer you go from your treatment, it's already looks like 2 years, the better it is. Obviously, the longer the remission is, the less likely it will come back.
Thank you so much for your response, Dr. Jain, and thank you for asking that question, Tom. I hope that answered what you needed. Okay, the next question here from Brad. Just completed 6 months of infusions, been on venetoclax 400 mg for 5 months with 7 months to go. Question is, my hearing has changed for the worse since I've been taking this medication. Will venetoclax have a side effect that hits your hearing?
Nothing that I'm aware of. That venetoclax causing the hearing issues. We use venetoclax obviously all the time. It's also a drug which is used for acute leukemias as well, quite commonly these days. So not that I'm aware of venetoclax affecting the hearing, but certainly, see an ENT specialist and see what they suggest. But I really don't think it is venetoclax or obinutuzumab, which you received before causing it.
Thank you for your response, Dr. Jain. The next question we have here from Janet. So what is your treatment suggestion for a 76-year-old high-risk CLL patient with many bulky abdominal and pelvic lymph nodes? If obinutuzumab and venetoclax is chosen, the doctor recommended a few weeks of steroids prior to treatment.
So it's a bit of a, so certainly bulky, if you have lots of lymph nodes in your abdomen, if you use the stimulated approach of Ven-O, which is listed, the risk will be what is called tumor lysis syndrome. Now, you certainly could consider steroids, to what is called debulking, that to get rid of the tumor a bit. The tumor may shrink a bit, the lymph nodes may shrink a bit, and that may make use of Ven plus O a bit more easier. Other thing, I mean, many times if we are really going to do O plus V, and depending on how big the lymph nodes are, really that is really, really bulky or bulky in the sense, it's like 15 centimeter, 20 cent, which is like really, really big, or versus like 7-8 centimeter. I many times just do Ven-O directly without using steroids or anything like that. So I think it's appropriate to use steroids. I think it's fine, but again, things could be done without steroids as well for a patient who may not have that many lymph nodes.
That is good to know. Janet, I hope that answered your question. Okay, Holly has another question. So she's asking, have you seen any benefit for patients working with an integrative oncologist alongside their medical oncologist? Is there anything helpful an integrative oncologist can provide during watch and wait or during treatment?
So again, we don't work with integrative oncologists to say at our center, in some sense. So I'm not really maybe helpful in a way my answer here. There are certainly people do lots of different things in the watch and wait phase, trying to prevent the disease from getting worse. Um, Most things have no so-called proven scientific benefit. So I kind of leave up to the patient, but at least we don't have this kind of a team here. Maybe other centers have it, but we really don't.
Thank you for your response, Dr. Jain. Okay. Seymour is asking, do you recommend clonoSEQ MRD testing for patients about to start therapy?
It's a very good question, and it's a bit of a uh, uh, so so MRD testing is recommended, but it's not routinely done for patients. So patients who are receiving time-limited therapy, basically, if you're getting venetoclax plus obinutuzumab, as Janet was alluding to, which is typically given for 1 year and then you stop. I think there is a um, relevance of doing MRD testing. MRD stands for measurable residual disease, which can check for low level of disease. Typically, MRD, most centers, first of all, many centers don't do MRD testing. Centers who do MRD testing most do what is with a test called flow cytometry, which can pick up one cancer cell in 10,000 normal cells, which seems pretty good. And that's what has been standard for CLL for many, many years. In the last few years, a test has come, which is called clonoSEQ, which is done by Adaptive Biotechnologies out of Seattle. It is an FDA-approved test for CLL patients. And it can pick up one cancer cell in 1 million normal cells. So it is much more sensitive to pick it up, to pick up disease, low levels of disease. We certainly do clonoSEQ quite a bit here as part of clinical trial practice. We do. Outside of a clinical trial practice, I think the role for clonoSEQ is evolving. I personally would do it, but again, I'm not recommending it to be done to everyone in the country right now, because as we generate more medical data in that regard, then we can be more comfortable with it. But certainly, if you're using just drugs such as ibrutinib or acalabrutinib or zanubrutinib, in that scenario, there's no role for MRD testing or clonoSEQ, in my opinion, or no standard role. There could be some specific roles, but yes, if you're using 1 year therapy, then I think there certainly I think there's a role of doing clonoSEQ testing, and at least we do for our patients here, or we have started to for our patients here, mostly in the last 1 year or so.
That's good to know about clonoSEQ. I know that we've definitely heard a lot about it. Awesome. Thank you so much for your response. And then thank you for your concern, Seymour, about Brad's question. It looks like that we did answer that one about the hearing. Okay. Holly is wondering, are there any supplements you recommend patients with CLL who are in watch and wait to not take?
It's again a difficult one. I generally say if they want to take a routine health supplement, multivitamin, things like that, it's okay. But again, most of additional supplements or very specific kind of extracts and things like that, we really don't know pros and cons specifically in the context of CLL. So I personally don't per se recommend any supplement to be taken for patients with CLL with the goal that it will improve their CLL. But I think if sometimes patients are spending a lot of money and a lot of time and effort and travel to go to some place to get some kind of a special therapy or whatever, I think it's probably not worth it, in my opinion. But again, people have different opinion about those things.
All right. Thank you so much for your response. Janet is wondering, is there any way a US doctor can use a BTKI and venetoclax combination?
So good question. So right now, BTK plus 1 combination is not approved in the United States. However, just yesterday, a press release was issued by AstraZeneca company that their clinical trial, in which half of the patients got chemotherapy, half of the patient got acalabrutinib, so the second generation BTK inhibitor, plus venetoclax, was positive. And so this is just a press release issued by the company, kind of what is called the top line data. I suspect, I would think, based on that, they will file for the FDA approval of this drug. Again, I don't know the timelines, but I would expect that within next year or so, if again, we don't know too much, but we just know the press release, the trial is positive, but that will lead to the approval of BTK plus venetoclax in the United States. And the BTK there will be acalabrutinib. So that there is a way. But having said that, I mean, I have lots of patients where we have used BTK plus Ven. Again, it just depends on the insurance company to approve it and the comfort level of the doctor who is prescribing it. Because if it's not approved, FDA approved, many physicians are not comfortable using it, and then insurance company may not be comfortable or may deny both the drugs to be given, together.
Thank you so much for your insight about that. And then I can also email you, Janet. I believe I have your info about any clinical trials that may be ongoing that you could also potentially join prior to FDA approval if you may be interested. That is venetoclax plus a BTK inhibitor. Okay. So Tom is wondering if you by chance know if there is an impact of forest fire smoke on someone with CLL or other blood cancers. They live in an area that is experiencing poor air for an extended period of time.
So nothing that I know specifically about and about CLL, but I'm sure people, I had some patients from San Francisco, and this not now, but some years ago, where they had a big fire and all those things. And I'm sure people have looked into it, but I'm not sure about the CLL specifically, but in general, the what has happened with the smoke. But I'm not aware of any specific studies about CLL or blood cancers to say what is the specific impact is. Obviously, it's going to be negative. Whether it's negative has been proven to be negative versus not, that I'm not entirely sure.
That'll be very helpful, or I guess the researcher that decides to look in that'll be great. And then as well, Tom, if we come across any publications or things, I'm happy to send those your way in the future around that topic. Okay, Mrs. Hankins is asking, do you have any recommendations to fight fatigue? 54 on watch and wait and seems to have periods of fatigue that last for 1 week or two sometimes. Other times she can almost forget that she has CLL. She exercises regularly and gets plenty of rest.
Yeah, so it's a tough question, because yes, patients with CLL have fatigue. And, sometimes it's difficult to tease out how much of that fatigue is coming from CLL, how much of this fatigue is coming from maybe other medical issues, life issues, other things, work, and kind of all things together. And, it's common for patients with CLL to have fatigue. Again, there's no, I would say, obviously, if the fatigue is truly coming from CLL and CLL is also worsening at the same time, the white count is rising, the lymph nodes are rising, blood, then yes, then probably you need treatment for your CLL. But if all other things are pretty stable, your oncologist says, okay, everything is okay, we just need to watch the disease, so it's a tough one, because, many patients with CLL will have this kind of mild to moderate fatigue. I would say that, just on the basis of that, many times I don't start patients on treatment, but again, I have seen that there are these other undiagnosed medical issues which we have picked up over the years, including low thyroid levels and low testosterone level for men, sleep apnea, and things like that, which were undiagnosed medical issues, or diabetes, like blood sugars are too high, were undiagnosed medical issues which could be contributing to fatigue. And because when you have CLL, your mind is thinking everything is CLL, 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 but maybe there are other things which are happening in parallel in the background, which you may not be paying attention. So I think it's important to talk to your primary care doctor and make sure the thyroid level is okay, and then there's no heart disease, and stress tests, depending on the situation, have been ruled out. But despite that, yes, there are patients with CLL who will have mild to moderate fatigue, and it likely will persist. Certainly the exercise and things like that, it looks like you do that, but I think exercise and kind of a routine like that, many times patients are not exercising, so I kind of encourage them to do that, and that may help as well. But it's a challenging thing when you are not treating the patient for CLL because they don't per se need treatment and they have this ongoing kind of fatigue.
Thank you for your insight there, Dr. Jain, and I hope that answers your question, Mrs. Hankins. Okay. All right, well, let's go ahead and just double check. It looks like we've answered all of our questions here. Thank you so much, Dr. Jain, for your help of answering everything for our patients. If anyone does have additional questions that they would like, I'll give you HealthTree's email that you are welcome to send over. Okay, so I also want to inform everyone of a free resource available to you called HealthTree Cure Hub. You can securely connect your medical records to track your CLL labs and tests in one place. You can become a Cure contributor and accelerate CLL research by participating in surveys. You can find clinical trials and side effect solutions. So access your free HealthTree Cure Hub account by visiting the link at the bottom of this slide. We'll also send you the Cure Hub link in a follow-up email within 48 hours after the event has concluded. I'd also like to mention when our next CLL webinar will take place. In August, we'll hear from Dr. Nadia Khan about why CLL patients experience fatigue and how it can be managed. Stay tuned on our event page or newsletter announcements for the specific date of this event and registration details. I will send links to these resources in the follow-up email.
Okay, thank you very much. I hope this was helpful and all the best to you guys. Good luck. Best wishes.
Thank you so much, Dr. Jain. Before we go, I also want to take a brief moment to thank our community sponsors without whom this would not be possible, AbbVie and Genentech. And thank you for helping us build a strong HealthTree community for CLL. I appreciate you all, and I hope to see each of you again soon. Don't hesitate to reach out if you have any questions about HealthTree or upcoming events by emailing cll@healthtree.org. And thank you so much again, Dr. Jain, for your informative presentation and support in answering our questions today.
Guys, thank you. Bye.
Have a great day, everyone.